Hi, can you hear me?
Yes, madam.
Okay, right. So I just talk to you. So good evening to all of you. On behalf of all the the members in the family medicine family, I welcome you all to the discussion today, which is very important, and it will be. I'm Dr. Malkanthi Galhena, uh, the consultant family physician as well as the college president. So. Nice to see you all have majority of you all have joined, and this is very fruitful discussion for sure. I can surely mention that because Dilini and Dr. Jayoda, my two registrars who were with me last 1 month, they have done a very good presentation with the participation of all of us together. So I thought of giving this knowledge to you all as well because it may that will be definitely it will make how your diabetes management need to be aligned with the guideline management, so which we need to practice accordingly after this now onwards as registrars, because you have to know the practice of best evidence based medicine, so in general practice or in primary care. So this is really good, and I hand over this to Dr. Dilini. She's registrar, as well as Dr. Jayoda. She will talk after the Dilini's the speech later. Right. So kindly, it's over to you, Dilini. So can you please start, and one word to mention before that. So in case of diabetes, the diabetes management, you should not think that it's just the management of sugar control, right? It's sort of identifying what are the reasons for this patient to have the blood sugar at the beginning to get the diagnosis as diabetes, and as well as why this patient is having, the specifically identify among the patient. It will be from patient to patient, different reasons may be behind to become the diabetic patient. And not only that, not as the initial management, but in follow-up management also, they used to come with uncontrolled diabetes mellitus status as well as the complication of diabetes mellitus. So if you know at the beginning how to diagnose and what is the reason behind, that is the risk factor for her to get the diabetes, and as well as in case of follow-up, so what are the reasons to go out of control and to the present with the complication of diabetes. So our total aim is to provide the patient safe patient management according to the best evidences, that is the guideline management, and how to diagnose and how to assess, because main focus is to prevent organ damage due to hyperglycemia. The most important end organ damage need to be prevented. So at the beginning, even we don't know whether the patient has the patient was suffering from diabetes for so many years, even though we diagnosed the patient today. So because of that, thinking that this chronic disease, which will affect almost all the organs of the body, especially the brain, heart, and well, the kidneys, even in arteries of the foot and the lower limbs, upper limbs, and all, and there is a higher chance to get infections, and even a pneumonia will get ended up as the pleural effusion, and patient might die in case of uncomplicated the uncontrolled diabetes. So because of that, the very first thing is to come to the diagnosis and then assess the damage that patient got, that is the end organ damage. We need to assess at the very first diagnosis, and as well as in consequent follow-up, the visits as well. Otherwise, no point of just keeping the sugar control at the time that patient comes to you, maybe having sugar control with very much control fasting blood sugar, but patient may be having very high HbA1c, right, with some symptoms. So you need to assess what is the stage of the disease, as well as what is the end organ damage by assessing the cardiovascular risk. Look, the very two out important things in your management should be, you have to identify the end organ damage at the very beginning, as well as the cardiovascular risk. So those two tasks need to be done
Diabetes.
each and every visit, right? So because of that, please listen to this thing carefully, having this idea behind, idea in the sense to correct diagnosis. Not only that, to assess the patient's end organ damage at the beginning as well as on the follow-up, and as well as assess the cardiovascular risk, and whether you need to go ahead with the parallel lipid management as well to the patient. So I will now hand over to Dilini to go ahead. It's over to you, Dilini.
Thank you very much, madam. So I'll start sharing the slides now. I hope I'm loud and clear.
Yes, you are.
Right, so we'll be discussing regarding under these topics. First of all, the introduction. It's a recall of what we already know actually. It's diabetes is a state of chronic hyperglycemia where genetic and environmental factors could play a role. So it's classified into type 1, type 2, or other specific types of diabetes or gestational diabetes. So I'll quickly run through this. Type 1 is an autoimmune disease where the beta cell destruction is seen. And type 2 is basically a non-autoimmune illness where insulin secretion is inadequate in a background of insulin resistance. And there are two other types, specific types and the gestational diabetes. So let's move on to what is important for us at primary care, starting with screening. Now, suppose if a patient, asymptomatic obese male with a family history of diabetes coming to our clinic for some other reason, does he warrant screening for diabetes? So the guidelines we have referred for these presentations are the ADA guidelines and the College of Endocrinology guidelines. So the ADA guidelines broadly categorize into 4 areas for the screening purpose actually. So there is one category called the universal screening of population and the high risk population screening, and the people with pre-diabetes screening, and patients with a history of GDM. So they have nicely put into a chart form. So if we first take the for category 1, so suppose if a patient of any age coming with overweight or obesity plus with one or more of the risk factors mentioned below, so he or she warrants criteria for diabetes or the pre-diabetes. So the risk factors would be if the patient is having a first degree relative with diabetes, or if the patient is coming from a high risk ethnicity, or if the patient was having a history of cardiovascular disease, or if the patient is having hypertension. Mind the cutoff values this time. Actually, the latest ADA guideline says the blood pressure of equal or more than 130 by 80. So the local guidelines actually is mentioning a cutoff value of 140 by 90, but this is the latest cutoff. And if the patient is having HDL cholesterol levels less than 35, or a triglyceride level more than 250, that also a risk factor that we can call for screening of this patient. And if patient is having, a female is having a polycystic ovarian syndrome, a physical inactive patient, and if a patient is having features of insulin resistance, that also falls into this category. And there's another category who warrants screening. They are pre-diabetes population. So I'll come into details of pre-diabetes later in the slides. And the next category would be the patients who are diagnosed with GDM. So they should be tested at least every 3 years. And the rest of the people, irrespective of any other factor, the screening test should begin at the age of 35 years. So the next category would be the people with HIV, especially before starting the antiretroviral treatment. So suppose if the initial screening tests were normal, the ADA says to repeat the next screening at 3-year interval. However, if the patient has developed any other risk factor, we can reduce the interval of screening. So it depends on the patient basis, mainly an individualized decision. Right. So a little comparison with the local guidelines, that is from the College of Endocrinologists for screening. So one thing they have mentioned that was not in the ADA guideline was the long-term treatment with medicines. If the patient is on long-term glucocorticoids or antipsychotics, that is also a factor that we need to consider in the history of the patient to warrant for a screening. And then right. So what are the screening tests available? So in primary care, we can easily do either a fasting blood glucose level or a 2-hour plasma glucose, the 75-gram OGTT testing, or the HbA1c. So the fasting plasma glucose, we need to ensure that the patient has not taken any calorie intake for at least 8-hour period. And the important thing during advising the patient while doing the 2-hour plasma glucose testing would be the patient, we should ensure the patient has had adequate carbohydrate intake, at least 150 gram per day prior to testing, at least the initial 3 days prior to testing. Otherwise, if the patient was unnecessarily fasting, it would give rise to false values. And then, of course, the HbA1c. So the American Diabetes Association, the newest guideline, have given this small assessment tool which can help us to actually categorize whom to screen. So this is a small questionnaire that can be filled by the patient while he is awaiting consultation, or even a nursing officer can tick these off quickly, so that if we catch this population early, then we can do the proper screening tests. So it's called the diabetes risk test. So we give some points according to the age, the gender, a history of GDM, a family history, hypertension, the physical activity or inactivity, and of course about the weight category. So out of 11 points, if the patient has scored 5 or more, they are at a high risk. So that would ring a bell in you to screen them further. So next would be, after screening, how can we come to a diagnosis of diabetes? So there are a few cutoff values that we can use where the ADA has given. So to diagnose as diabetes, if the fasting blood glucose level is equal or more than 126, or the 2-hour plasma glucose during the OGTT test, if it's more than or equal to 200, or the HbA1c level is equal or more than 6.5. Additionally, in a symptomatic patient, a simple random blood sugar level equal or more than 200 also categorizes this diabetes into a diagnosis. So is that it? We need to confirm the diagnosis. So suppose if an asymptomatic patient coming and we do this test, we can't really diagnose by one report, especially in the asymptomatic population. It has to be at least 2 abnormal test results. So the guideline says if a one result is abnormal, we need to repeat it without a delay. So you can repeat the same investigation or a screening test of a different category that I have mentioned above. So if the patient is symptomatic, as in if the patient is having classic features of hyperglycemia, any single diagnostic test would confirm the diagnosis of diabetes. Or as I mentioned earlier, a random blood sugar of equal or more than 200 also gives us a confirmation of the diagnosis. So now that we have diagnosed diabetes, now suppose if a patient comes with a fasting blood sugar report of 112 who has these risk factors. smoking history, and a sedentary lifestyle. So can we really categorize him into a diabetes? Or what does this patient falls into? So this is a common scenario we come across. And let's see what our next plan of management would be in this kind of patients. So there's an entity called prediabetes. So prediabetes is a state where the blood glucose level is not high to diagnose as diabetes as such, but there is some abnormal carbohydrate metabolism. So to define prediabetes, there are some cutoff marks. So the same screening tests can be used. So the cutoff values would be fasting between 100 to 125 and 2 hour plasma glucose levels between 140 to 199, and the HbA1c levels falls between 5.7 to 6.4. So these patients fall into prediabetes category. So why catching these prediabetes are very important in primary care? So because the conversion to diabetes from the prediabetes state is around 4% to 20%. So quite a significant number. So this state of having prediabetes can actually increase the microvascular and macrovascular complications. So which is a problematic thing. And if we treat this prediabetes state, it would actually delay the progression to diabetes and can delay the diabetes related complications as well. So the ADA guideline have given some new things regarding the lifestyle and the behavioral changes for diabetes prevention actually. So it falls under the DPP trial, Diabetes Prevention Program trial actually. So they have mentioned if we cater intensive lifestyle behavior and physical activity, it could actually prevent the diabetes progression. So they have mentioned achieving at least a 7% of a weight loss of the initial weight. So the weight loss has to be around 1 to 2 pounds per week. And then regarding the physical activity, they have mentioned it is better to engage in moderate intensity physical activities like brisk walking around 150 minutes per week. So I'll come to elaboration of this later on in the next slides. And then we were talking about pre-diabetes. So what is the management that in the primary care level we can give for our patients? So first of all, we need to identify the risk factors and we need to modify those. So it could be the lifestyle modifications, MNT, like medical nutrition therapy, and engaging them in physical activities. If the patient is smoking, we can advise to stop smoking and avoid alcohol and avoid stresses. And of course, cardiovascular risk reduction, like controlling the hypertension and dyslipidemia. And if the patient is overweight or obese, at least a 7% to 10% of weight loss is recommended. And there is also a place for pharmacological management in the pre-diabetes state itself. If the patient falls into obese category or overweight category, or if the patient is less than 60, or if a female with a history of GDM. So the preferable drug treatment would be metformin. And then, as I've already mentioned, we need to monitor the progression of the conversion to diabetes from pre-diabetes at least annually. So that is basically the management of pre-diabetes. So we come to diabetes, basically the pharmacological and non-pharmacological management. So in non-pharmacological management, now actually it's not
less than 60 years.
Not really following the doctor's orders anymore. It's basically a more or less a patient-centered diabetes care we need to provide. So it's an individualized treatment plan. So we are engaging with the patient and we discuss with the targets that we are going to achieve and engaging the patient's wishes as well. So it's more patient-centered and achievable targets. So it will give a good outcome at the end. So they have given a summary of the things that we need to look at the onset of the management. So we need to assess the patient characteristics. Like in the history taking, we need to look what are the individual's priorities are and what is his current lifestyle, his any behaviors like smoking, alcohol, things like that. And if the patient is having any comorbidities now, so we need to address that. And then in the history taking also, we need to consider there are some specific factors that would impact the choice of treatment, like what are the drugs that he's already on, so that will if we add something more, if it's going to interact with the new drug, or the side effect profiles of the medications, and of course the availability of the drug and the accessibility and the financial stability of the patient. So these everything we need to consider, and then we need to come to a shared decision making with the patient to create a achievable management plan. So we need to finally agree on a management plan, SMART goal they call it. So it has to be a specific, measurable, achievable and a realistic time limited management. So after agreeing on such, we need to implement it and regularly monitor it with us providing ongoing support to the patient. And then not only implementing it, we need to review it and make necessary arrangements if there are any problem arises. So it's like a summary of the patient-centered diabetes care they have given. Right. So there's another term called comprehensive medical assessment that we need to do at primary care when we get a patient with diabetes. So it starts with the basic history taking. So in the history, we need to consider the age of onset, the characteristics of at the onset, what was the patient having, and the family history and the comorbidities. In the history, we need to address those as well. And of course, the behavioral factors, the eating patterns is important so that we can advise the patient on his eating behaviors and weight losing advices, and the physical activity, the sleep behaviors. If the patient is on tobacco, alcohol usage, and the medications and vaccinations patient is currently on. And of course, the technology use. If the patient is capable of using the health apps, or if the patient is accessible to blood glucose monitoring, like a glucometer, if it's feasible for the patient to use. So those little things are also important in primary care initial assessment as well. So, and regarding the social supports he's having. Next come the physical examination. Of course, these parameters are important to examine thoroughly. So usually the BMI, we have to check at the initial visit and at every follow-up visit and in annual visit as well. So same goes with the blood pressure measurement, and fundoscopy is very important in annual visits. So if we see any changes, we can refer to the ophthalmologist. And of course, comprehensive foot examination. So we need to look for any callus formation, foot deformities, ulcers, and especially checking for peripheral pulses, any features of peripheral vascular disease. If we suspect things like that, we can check the ankle brachial pressure index and do the referral accordingly and timely. And then checking the vibration, the monofilament testing, are of importance. And then, of course, we might forget to do these things like screening for depression, anxiety, and any eating disorders, their cognitive ability. So in the primary care initial visit, also at the annual visit, it is better to do these screenings as well. So what are the investigations that we need to order? So this everything comes under this comprehensive medical assessment. So HbA1c, if the patient has not done any HbA1c for the last 3 months, then we can order HbA1c to see the glycemic control. And of course, things like lipid profile, liver function tests, urine albumin to creatinine ratio, creatinine levels, we can see. Vitamin B12 we don't really do routinely, but of course to see any vitamin B12 deficiency in a chronic metformin taking patient, a full blood count would be enough. So, and if the patient is on ACE inhibitors or ARBs or
B12.
diuretics, serum potassium levels, electrolyte levels, we can check. So it is like a summary of the medical assessment, including the history, examination, and investigations. So then we need to summarize a treatment plan. So this is actually summary what I have already told. So in the treatment plan, we need to identify the lifestyle management, the pharmacology management, and the non-pharmacological management as well. And of course, the addressing the comorbidities and the diabetic complications as well, assessing the risks and assessing other microvascular and macrovascular complications. And we need to set some goals like glycemic targets. So in the non-pharmacological approach, there's a new term called DSMES, that is Diabetes Self-Management, Education and Support. So it is a program where the patient is allowed to gain knowledge regarding diabetes, the disease, how the medications would help him in preventing the complications or rather control the disease. So that makes both the parties, the doctor and the patient, to have an informed decision making, so that the patient would have a self-care behavior, a problem-solving behavior, and they would actively collaborate with the medical team to finally get a positive outcome. And there's a term called medical nutrition therapy, where we use the nutrition as a medical therapy, as in we do a individualized meal planning according to each patient. So we can refer to the nutrition team to get the best use of it. So they have found out that a properly delivered MNT would actually decrease the HbA1c. Just by the MNT itself, it would decrease the HbA1c by 1% to 2% without any pharmacotherapy. So they have recommended to go with the plate method. I think everyone is aware of what the plate method is. So half of the plate, non-starchy vegetables, and the other half is again divided into two with protein and the carbohydrate food as well, where this image illustrates. And a word about the physical activity. So there are 3 variants of physical activities that we can advise the patients to do. Those are moderate intensity workouts, muscle strengthening workouts, and the flexibility and balance related exercises like yoga. So moderate intensity activities, we can advise the patient to go for a brisk walk, do jogging, swimming, or cycling. This has to be done at least 150 minutes per week. And the patient should not have rest more than 2 consecutive days. So we can advise at primary care, this can be done. And there are also muscle strengthening exercises as well, push-ups, calf raises, and things like that. And also yoga for the flexibility. And another important non-pharmacological management would be smoking cessation. So we must encourage the patients to stop using tobacco, and even e-cigarettes. The next would be improving the psychosocial care, which is really not addressed properly. So we have to think about that as well. There's a health toolkit questionnaire that is given at the ADA website, so you can go through that. Of course, managing stress. And then they have mentioned about a good quality sleep. Sleep between hours of 6 to 8 hours, they have recommended. So sleep less than that or more than that could interfere with the glycemic control. Let's talk about the glycemic targets that the patients have to achieve, or rather we have to tell patients that you need to achieve. So the HbA1c, it's better if we can have it less than 7%, and the preprandial capillary glucose between 80 to 130, and the postprandial less than 180. However, the HbA1c targets can be modified according to some patient characteristics. We can go easy on some patients, but more stringent on some patients. Like suppose if a newly diagnosed patient, so we can have a glycemic target really less than 7, so 6.5 and things like that. So if the patient is highly motivated and is capable of engaging in the physical activities, so we can get down the HbA1c a little lower side, which is good for the patient in the long run. So before moving on to the pharmacological management of diabetes, I would like to talk a few words about diabetes and other cardiovascular disease risk management as well. Because we get patients not only having diabetes, but with other comorbidities like hypertension, CKD and things. So if a patient with diabetes and hypertension, if the patient is having persistently elevated blood pressure of more than 130/80, that patient qualifies for antihypertensive treatment. And the newest target BP goal is less than 130/80. Previously, it was 140/90. So the threshold is 130/80 now. So that we need to remember. And another small question: if a patient who is already diagnosed with diabetes but with no other risk factor coming to our clinic with his usual diabetes medications only, so is there any other medication that we need to think of adding? So there is a section on diabetes and statin therapy. So it is mainly divided into two parts: primary prevention and secondary prevention. So primary prevention is when a patient has not had any atherosclerotic cardiovascular event. So that means MI, a cerebrovascular accident, or PVD. If the patient has not had any that kind of event, he goes under the primary prevention category. So in that population, we should have the LDL goal of less than 70, or a 50% reduction in the baseline. So in that category, of course, patients between ages of 40 to 75 years, we need to add moderate intensity statin. So if that category doesn't have any other risk factors, we have to start them with a moderate intensity statin. But if the same population, the age category 40 to 75, if they have another additional risk factor, then we need to convert it into a high intensity statin or as an ezetimibe, depending on the condition. So the more younger population, 20 to 39 years, of course, we need to assess the risk and then decide on adding the statin. So if you think the risk is high, you can add a moderate intensity statin. If not, you can just leave at that point. So the more elderly population, more than 75 years, they also, after assessing the risk, we can add the moderate intensity statin. What we need to remember is, for the primary prevention, the age category between 40 to 75 who does not have any serious risk factor, we need to start with a moderate intensity statin. Then the next group would be the secondary prevention group. Secondary prevention population is actually the people who have had an atherosclerotic cardiovascular disease. So they, irrespective of their age, have to start on a high intensity statin. So that we need to remember. And their LDL goal has to be less than 55. Or you can add the ezetimibe if the patient is on maximum tolerated statin dose, and if the LDL target has not met, we can add another drug. So in this secondary prevention group, irrespective of their age, we need to add high intensity statin. So what are high intensity and moderate intensity statin? The commonly used statins, the ATOA 40 and 80 falls into high intensity statin therapy. And the rosuvastatins 20 to 40 falls under high intensity statin therapy, whereas atorvastatin 10 to 20 and rosuvastatin 5 to 10 falls into the moderate intensity statin therapy. So that's about the non-pharmacological.
Can you go back to the slide, the risk assessment? There, primary prevention, right? So can you show the clinical scenario? Just to give you some more illustration. Here the 45 years old male with diabetes without any, the cardiovascular risk, right? No risk factors. Atherosclerotic cardiovascular disease. So no any history. That is, the no heart attacks. Atherosclerotic cardiovascular diseases are TIA, the myocardial infarction, then PVDs will, stable angina, unstable anginas. So this will categorized into ASCVD and CVS risk factor, no CVS risk factor in the sense. Cardiovascular risk factor, we have to, there are cardiovascular risk factors identified by the WHO, that is called the increased, the cholesterol levels, high blood pressure, then smoking, diabetes, and those things, right? So we have to consider those things. Can you go to the next slide, please? So here, I need to give you more emphasis on this, right? Because this is a very important part in this presentation. There, when you think about whenever a patient comes with diabetes, you have to think about whether this patient needs lipid management as well or not. So that is the important question that you have to ask. Not only the diabetes management, but also think about the lipid management, whether this patient needs. So that is why, the Dilini mentioned about this. In such a case, if patient didn't have any, the past history of coronary, the atherosclerotic cardiovascular diseases, which I have mentioned, like, the heart issues, and as well as, the TIA or stroke, and then the PVD, like that. If patient didn't have that, then in case of the LDL target is 70. But if the patient has that, the type of thing, we used to call it's a secondary prevention. Secondary prevention in the sense we are not going to give him another the cardiovascular event on that patient, because already he got it, but we have taken the responsibility to not to have another event. That is called secondary prevention. Primary prevention in the sense, if without having, patient didn't have any the evidence that patient had the mentioned events of cardiovascular events, but we are totally have taken the responsibility to prevent him going into any the cardiovascular event. So in such a case, our goal should be less than 70 LDL. We are targeting for LDL, right? in a lipid profile, mainly we are targeting now for LDL, right, according to the guidelines, although they are mentioning about, you know, a non-LDL, non-HDL cholesterol also they mention, but here guideline says the LDL. So you have to look at the patient's LDL level in a lipid profile. So each and every patient who comes at the initial visit, it's a must for you all to, you know, do the lipid profile in a patient in order to decide this primary prevention, whether this patient need or not. This is not just the management of diabetes by giving drugs, but think about in the parallel primary prevention of lipid management, whether he needs to prevent this CVD event. So in such a case, this is the goal, right? And but keep that in mind. Out of that, again, you have to clearly get into your mind, right? If the age is, you know, the 20 to 39, so we'll say 20 to 40 years, we have to start, you know, this so-called the statins after assessing the cardiovascular risk. How do you assess the cardiovascular risk? The cardiovascular risk is in a patient without having any history of cardiovascular events in the past, right? Otherwise healthy patient. So once the patient comes to you with history of diabetes, do the lipid profile and get, you know, the WHO cardiovascular risk assessment chart. That has to be there with your on the table, right? In primary care physician, it's a must. So you can download it. In our clinics, we use it. Dilini and the Jayoda and all other trainees are being trained to use that. So in such a patient, if patient didn't have any history about CVD events in the past, then you have to get that. If the patient belongs to this category, 20 to 40 years, definitely you have to assess the risk, right? So in such a case, if the risk is more than 10%, then we used to call the patient is in the moderate risk. So we are going to start 10 milligram of atorvastatin or 5 milligram of rosuvastatin, right? That is what she told according to the statins, you know, the potency, right? The potential of the action of the statins, we are categorized accordingly. So, but the problem is, take home message is you have to assess the risk up to 20 to 40 years in a healthy patient. But we'll say no evidence any CVD risk, but patient is 40 to 75 years. So without any CV cardiovascular risk, without the primary prevention, in the sense we are not talking about the patient who had cardiovascular events, but here no such cardiovascular events in the past, but age, you know, the difference. So age is 40 to 75 years. So, but in such patients, right, without, you know, the assessing the cardiovascular risk, you can start moderate intensity statin. So because the patient has, you know, the patient's arterial system has been damaged to some extent, right? And having diabetes, it has been double. So we assume that patient may be having atherosclerotic disease. So that is why we are going to add the moderate intensity statins. So this is very clearly you have to take into your mind. This is what the take home message I want to give, you know, from the Dilini's, you know, the presentation, right? And another category is 40 to 75 years, but patient is having CVS risk. So what are the CVS risk? Risk, that is having the CVS risk, cardiovascular, the system risk. So what is that? So that is strong family history of, you know, the premature heart disease, right? Heart disease or deaths among the family, right? And the patient also having, you know, the cardiovascular risk of such things, smoking, and some of those other risk behaviors, right? Then in such a case also, not only, you know, the moderate intensity, age with CVD risk high now, in such case we can go for the high intensity statins. That is, you know, we can go for the 40 milligram of atorvastatin or 20 milligram of you know, the rosuvastatin. Not only that, we can, if after, you know, the seeing that if the patient is not responding for the such, you know, the high intensity statins after about 3 months life, then we can add ezetimibe as well, right? We are not using PCSK9 inhibitors in Sri Lanka. So because of that, we can think about these combination as well, but it's in a gradual stage. Not at once, we are not going to give the combination. If the patient is 75 years or more, then we are going to give them the moderate intensity statins. That is assessment, because already that is because of the age, right? Moderate intensity statins, but after risk assessment, like the having 20 to 39 years. But Dilini, can you tell me the rationale behind, because moderate intensity statins after risk assessment, why, what is the difference there? You can't also, no? We'll take into the consideration and we'll come to that later. But keep that in mind for the primary prevention with the patient who are the patients. Any CVD events, then you have to think about reducing the LDL to 70 or less, but age category 20 to 40, of course, you need to assess the CVD risk. Above 75 years as well, need to assess the CVD risk for both. We are giving moderate intensity statins. But 42, the 75 years up to, the patient doesn't have any risk like the family history or any other things which I mentioned, then you have to think about the adding, the without assessing, no need to assess the CVD risk by the WHO risk assessment chart. Okay, and even 40 to 75 years, again, those two categories, no need. So that is the rationale. You are going to manage patients with diabetes without having any evidence of CVD events, please think about the adding the statins. That is because I told you to prevent end organ damage. I told you at the beginning, for that we need to assess CVD risk on some patients, but some patients so we don't want. So in case of primary prevention, but secondary prevention, nothing, no need to assess the risk by using the WHO risk, because already patient had the CVD event. So in such a case, they are a high risk. So we can go for the high intensity statins parallel with the diabetes management. And in the meantime, the diabetes management is very important to have to the up to the standard the control of diabetes, as she mentioned before. The Jayoda will let you know how to select such the diabetic treatment. So it's over to you, Jayoda. Thank you very much, Dilini. It's really, really comprehensive.
Thank you, madam.
So I must give you the special thanks to both of you all. But out of that, Jayoda, she's pregnant and she's having some issues. Sorry to keep you, up in the late night. So, but anyway, she is giving such a very big commitment because of you all, as the colleagues, to give this knowledge to you all. So I appreciate it very much. It's over to you, Jayoda, now.
Thank you, madam, and thank you, Dilini. So, yeah. Yes, I hope you can see my slides. So I'm going to sort of briefly tell you about the pharmacological management of type 2 diabetes. This is going to be an overview. Like Dilini said, it's based on the ADA guidelines, 2023 ADA guidelines, and then the 2022 College of Endocrinologists guidelines, the local guidelines. So this will in fact be a sort of a summary of the both. Mostly both the guidelines sort of had the similar sort of management strategies. However, this will be a concise summary and it will give you an overview and for you to read more on it. So the pharmacological management, now to start with, I'll just tell you about this case. Let's consider a 63-year-old male patient who is a diagnosed patient with diabetes, hypertension, and dyslipidemia, who presented for routine follow-up with a fasting blood sugar of 167. He's currently on metformin, glycoside, and sitagliptin, the maximum doses of all. and with good compliance. So what will the next step in management be? So generally, when you consider a patient having diabetes, there will not be a sort of a, an algorithm which works for every patient. There is not a set algorithm which works for all the patients. So say if a patient is started on metformin, the next drug of choice will depend on so many factors. And it won't be just a fixed regime for everyone. Keeping this case in mind, we'll see how we can manage diabetes in primary care. So initial management for anybody, pharmacological management is initiated as soon as the diagnosis of diabetes is made, along with lifestyle modifications. So about the diagnosis, Dilini explained it very well, how the diagnosis can be made. So once that diagnosis is established, you have to start on pharmacological management. And when you start that, you need to have a patient-centered approach for better outcome of management and for a better therapeutic outcome. Generally, why we start early pharmacotherapy is because most of the individuals progress over time. If you do not start the patient on any drugs at the beginning itself, they will not have proper control, and it cannot be say lifestyle management alone will not uh, with the lifestyle modifications only, you will not be able to have a good glycemic control. And the other thing is, most individuals, of course, like I said before, they will fail on MNT alone, mostly. And also because of something called metabolic memory. That is, if at the initial stage, if you do not control the hyperglycemia, later in life, they might suffer consequences. They might suffer end organ damage more rapidly. There will be worse control over time if you do not control it at the beginning itself. Right. And that is something to do with, say, you must have heard, like we discussed something called legacy effect. That is more or less the same thing. And early aggressive control improves long-term outcome. And poor control in early stages leads to higher long-term complications. Because of these reasons, we tend to start early pharmacotherapy. And when making the drug choices, when we consider, okay, what do we start with the patient with? So you have to consider so many things. So these are also considered when you add on a second drug as well. But when making the first, when the trying to decide what to start the patient with, these are extremely important. So effectiveness of the drugs in terms of metabolic response, very important. That is very important. And of course, the safety and the tolerability of the drug, and side effects, including the risk of hypoglycemia, and how the risk of hypoglycemia can affect an individual depending on the age, level of activity, and the occupation, etc. And the impact the drug has on weight, and whether or not the patient has established atherosclerotic cardiovascular disease, and whether or not the patient has chronic kidney disease, or having high risk of kidney disease or heart failure. And the treatment goals, that is the target HbA1c. The HbA1c target, again, it won't be specific, it will be specific. The target HbA1c for individuals differ depending on their age and certain other factors. So, and the risk from other drug interactions, maybe the patient may be on other drugs for other diseases. So we need to consider the drug interactions, and of course the patient preference and the needs. And in fact, we have to consider the economic status of the patient as well. So the first line pharmacotherapy, considering all these things, the first line pharmacotherapy, generally metformin, it should be continued as long as it is tolerated and not contraindicated. And if so, I will not say mention the advantages and disadvantage of metformin here, but it's generally contraindicated in patients having an eGFR less than 30. And if gastrointestinal side effects are reported, that is what patients complain of usually. And if that is there, we can consider extended release metformin. And if you do consider like extended release metformin, you might even be able to go for a once daily dosing. Then the other available options are SGL2 inhibitors and DPP4 inhibitors, sulfonylureas, pioglitazone, GLP-1 receptor agonists, and insulin. These are the other available options that we can consider as first-line therapy. In case metformin is contraindicated or a patient cannot tolerate metformin even when you give the SR preparation. So other thing is, in some, SGL2 inhibitors can be considered early as first-line treatment. So, I mean, inhibitors, for example, these empagliflozin, these kind of drugs can be considered as first-line treatment. So those patients are the ones who have cardiovascular comorbidities, that is established atherosclerotic cardiovascular disease, or if there is any indication of high risk, high CVD risk, or if a patient has chronic kidney disease with a eGFR between 30 to 60, or if a patient has heart failure with an ejection fraction of less than 45%. This is not a must to start these patients with an SGL2 inhibitors, but it can be considered as first-line treatment. Then there are certain instances where we consider initial combination therapy. So there is a bit of a controversy between like how you add a second drug, say. So the intensification of our diabetes pharmacological treatment in diabetes can be done in two ways. That is, you can either start with an initial combination therapy, or you can go for stepwise intensification. Generally, initial combination therapy has its own advantages. That is, for instance, in initial combination therapy will establish better control at times, and also this tighter control will lead in lead to ultimately having lesser complications in the future. And usually, initial combination therapy is considered when patients present with HbA1c levels about 2% above the target HbA1c. So in those, you can consider initial combination therapy. So initial combination therapy can be either with an oral drug or insulin. So here, these are the things that these are the instances in which we consider initial combination therapy with insulin. So in that case, that will be metformin with the insulin, coupled with an insulin. So here, these are the, these are the instances in which we consider the combination therapy with insulin. One is if there are features of catabolism. That is, if there is glucose toxicity. Right. In that case, say it will this glucose toxicity will be reflected by unintentional weight loss of say greater than 5% of body weight over 6 to 12 months. And if there are features of ketonemia and hypertriglyceridemia, and if there are severe symptoms of hyperglycemia, like severe osmotic symptoms, and if the HbA1c levels are greater than 10%, and if the random blood sugar levels are more than 300. In these instances, we can start a patient on a metformin plus an insulin. And when to intensify treatment. So like I said before, initially we discussed when to start combination therapy. But this is when the patient is when to start a patient on a second drug when a patient is already on metformin. So is when you consider when to intensify 0.5% above the glycemic target. And this can be done by re-evaluating the medication regimen and medication taking behavior at regular intervals, say every 3 to 6 months, we need to monitor these patients. And we have to adjust these medications as needed to incorporate specific factors that impact the choice of treatment. And again, you should not delay intensification of treatment for these patients who do not meet treatment goals. You don't wait on it to intensify treatment. And so this stepwise addition that we discussed before, that is done to maintain the HbA1c at target, and also to provide a clear assessment of the positive and negative effects of the new drugs. So if you start a drug, if you keep adding one drug at a time, you can clearly assess if there's any positive or negative effect of that particular drug, rather than starting two drugs together. And also to, of course, to reduce the potential side effects and to reduce the expense to the patient. So yes, then when we consider intensification, what do we consider as the second line treatment? So generally, we say, now the latest guidelines say that if you have a high atherosclerotic, if you have a high CVD risk, and if the patient has a heart failure, or if the patient is suffering from CKD, it's best to start the patient on an SGLT2 inhibitor or a GLP-1 receptor agonist. But here in Sri Lanka, of course, GLP-1 receptor agonists are not readily available. These GLP-1 receptor agonists, in fact, are mostly injectables. There is only one oral form, which is semaglutide, but the others, liraglutide, exenatide, and some others, almost all the others are injectables and are expensive. But these SGLT2 inhibitors, it's readily available, and is also available in the government sector. At times it is available, right? So these two drugs are considered in these patients because of their cardioprotective and renoprotective functions. So here's the sort of algorithm that we follow in these kind of patients. So you start on the SGLT2 inhibitors, and if these drugs are, these are contraindicated, or if they are not tolerated, of course, you will have to consider to start on a GLP-1 receptor agonist. And then even with that, if the patient is not, if the glycemic control is not achieved, you can start the patient on a DPP-4 inhibitor, if the patient is not on a GLP-1 inhibitor receptor agonist, that is. Or else you can start on a basal insulin, or a soluble insulin, or if there is no heart failure, this is for CKD. So that is the general algorithm that we follow for these patients. And on SGLT2 inhibitor, and even with that, if it is not controlled, and even with that, if it is not controlled, to add a basal insulin and say. Yes, so a little bit on the SGLT2 inhibitors, because there is much emphasis given to this drug class in the latest guidelines. So the examples are empagliflozin and dapagliflozin and canagliflozin, right? So these are the, so what is readily available here is the empagliflozin. That is the one which is available in the government sector at the, currently. The mechanism of action of these is that it reduces the renal tubular glucose resorption, producing a reduction in blood glucose levels without stimulating insulin release. So we know that most of the drugs that are used in the diabetes, they act on the pancreas, and they increase the insulin, either increase the insulin activity or insulin secretion. But the mechanism of action of these is completely different to that, where what they do is they produce a reduction in the blood glucose levels by increasing the excretion of the glucose from the kidney with our urine, that is. So there is no stimulation of the insulin release. The contraindications to these drugs is if the eGFR is less than 45, you do not consider this in the patients with that. And also if there is a history of decay, again, if there's a history of recurrent decay, again, we do not consider in these patients. I mean, if there is such a history, we do not consider SGLT2 inhibitors in these patients. So advantages of this drug is that it has a lower risk of hypoglycemia, and it has a function of weight loss, right? So weight loss, when you consider, it says there is a weight loss of about 1 to 4 kilograms over 4 months to 2 years. And that sort of a weight loss can be achieved through starting empagliflozin. I mean,
Dr. Jayoda, your line is not clear sometimes.
and there is also a reduction in the systemic blood pressure. There is more effect on this, the systemic blood pressure than the. Sorry, my line is not clear.
Yeah, sometimes it happens, you know.
Oh, wait, madam. Is it better now?
Yeah, now better. To carry on.
All right, sorry. Sorry. Yes, I hope, let me know if it's not clear again. So now, like I said, there is a reduction in the systemic blood pressure, and generally it has more effect on the systolic blood pressure more than the diastolic blood pressure. And this reduction of blood pressure, initial reduction in blood pressure, is due to the volume depletion and the diuretic effect. And the long term, there is a long term effect of reducing and keeping the blood pressure lower. That is due to the inhibition of the renin angiotensin system and the weight loss, which is affected by the drug. So this, we say, is ideal for patients, diabetic patients with hypertension and obesity. And other thing is that, of course, we discussed this before as well. It reduces the cardiovascular mortality in patients with established atherosclerotic cardiovascular disease, and then it improves renal outcomes in patients with nephropathy. And it can also be used in patients with long-standing diabetes, because their action is independent of beta cell function and insulin secretion. So some of our patients who are on metformin, glycoside, sitagliptin, that combination usually. In our clinics, mostly you see that combination. So for those patients, if the glycemic control is not achieved, and when we decide to start on an insulin, they are usually a bit reluctant, because one thing is, of course, they have a needle phobia, and because of the expenses and the hassle it carries, they usually do not like to start on insulin. So for those patients who are chronic diabetes patients, for those who've been having diabetes for over 20 to 30 years, whatever even when you add another oral drug, another secretagogue or any other drug, they might not really benefit, because their pancreas is exhausted and will not produce any more insulin. For those kind of patients, of course, when you start on the SGLT2 inhibitors, at least for some time, you will be able to achieve some control, because the mechanism of action is independent of the pancreas and the insulin secretion.
Jayoda, how much is the weight loss? Jayoda, how much is the weight loss? You know the weight.
Madam, it's about it's about 1 to 4 kilograms over 4 months to 2 years.
2 years. No, right. Okay.
Spans. Yes.
Okay.
So other adverse effects that you need to be mindful about is, one thing is gentle mycotic infections, because there will be detectable concentrations of glucose in urine once you start this drug, and that will facilitate the onset of mycotic infections. And other thing is this risk of hypotension. So we discussed earlier that there is be reduction of their SBP mostly. So the risk of hypotension and volume depletion due to this osmotic diuresis is also more, which is accompanied by increased urinary frequency, thirst, and orthostatic hypotension. So therefore, we generally say there is a bit of a risk for patients who are more than 75 years of age, and for those having a EGFR of less than 60, and for those who are on the volume depleting drugs. So you have to, when you start a patient on SGLT2 inhibitor, especially in the elderly, you have to really revive their antihypertensives if they are on antihypertensives, and or else or on the diuretics. And you have to recommend careful use of other volume contracting drugs. So there is high risk of euglycemic decay. So if decay happens, you have to discontinue immediately. So why decay happens is because there is with this there is rapid increase in the urinary glucose excretion. So the urine glucose excretion will be more, and there will be a rapid decline in the plasma glucose levels, and therefore a decrease in the plasma insulin levels, with a compensatory increase in the glucagon levels, which can ultimately lead to a decay. So there is a high risk of decay, euglycemic decay. And if that happens, you have to discontinue immediately, and you cannot restart the patient on SGLT2 inhibitors. And also there is a general risk of UTI. And it's also said that it can induce some dyslipidemia with dapagliflozin. And Fournier's gangrene is also reported, which is rare. And canagliflozin increases the risk of lower limb amputation and fractures. That is, in literature, it is said to have a higher chance. So these are the adverse effects that you need to be mindful about. So with that in mind, when you start a patient on an SGLT2 inhibitor, there are certain things that you need to, as a doctor, you need to, as a family physician, you need to be mindful about these things. So before you start a patient on an SGLT2 inhibitor, you have to perform a baseline EGFR and a serum creatinine, because AGFR must be above 45, and you need to have a baseline serum creatinine. Why? Because generally, due to its mechanism of action, there will be a drop in the EGFR and the serum creatinine levels in the initial stage. But that is to facilitate the action of the drug. And you have to repeat the EGFR and the serum creatinine in 1 month to see if the drop is drastic, right? And you have to stop the drug if there's a 30% rise of the serum creatinine. But if not, you can continue the drug and then repeat in another 1 month's time, or maybe in a couple of months' time, to see if it has stabilized. And another thing is that you have to review the antihypertensives, like I said before, and you need to repeat the HbA1c after 3 months to see if we have met the HbA1c target. And other thing is reduce the dose of sulfonylurea by 50% if the HbA1c target is met. Why? Because the efficacy of sulfonylurea is also a highly efficacious drug, and SGLT2 inhibitor also has a good efficacy. So when you start the patient on an SGLT2 inhibitor, although it is not a drug which causes hypoglycemia per se, it can induce lower blood glucose levels because of its action. Right? So because of that, you might, if the HbA1c target is met, you can come down on your sulfonylurea. You don't try to omit it at the same visit, but you see the HbA1c and initially reduce the dose by 50%. And if you can go, if the glycemic control, the HbA1c targets are met, ultimately maybe you can even withhold the sulfonylurea or with the sulfonylurea. Then the advice given to patients at the time you start this is you have to tell the patient to drink adequate water, that is about 6 to 8 glasses a day, because of the volume depleting effects it has, and also to reduce the sort of to dilute the glucose in the urine so that the chance of mycotic infections are less, and also to monitor the weight at home because there's a weight loss effect, and check the blood pressure at home if and when possible, and of course to monitor blood sugar at home if and when possible. And then other things that you have to tell the patient is to clean the perineal area with soap and water, and inform the doctor if you notice redness or itching in the perineal area, which is indicative of some mycotic infection. And avoid ketogenic or very low carbohydrate diets. Yes, so diet control is necessary, but you have to avoid a keto diet, and you have to avoid taking very low carbohydrates because of this efficacy of the drug. And stop medication if sick, and if the patient cannot eat and drink well, you have to ask the patient to stop it temporarily, and also to stop the medication at least 3 days before planned surgery, which requires fasting. Yes. So moving on from SGLT2 inhibitors to our, how we go about intensifying treatment. So in patients, we discussed what to do if the patient has a CVD risk and what to add, how to add. But here we are discussing about patients who do not have a CVD or risk or CKD. Then the choice of second line treatment depends on many other factors. One thing is the glycemic goal and the weight management goals, and of course the cost and the access to the drug, and risk of hypoglycemia, and of course the individual preference. So addition of each new drug to metformin generally reduces the HbA1c by 0.7 to 1%. Each drug has its own, I'll come to that later. Each of the drugs has its own level. The level, the HbA1c reduction level. You measure the efficacy of the drug or by how much it reduces the HbA1c. So for each drug it depends, but generally we say when you add each new drug, you have to keep in mind that it will in average it will reduce the HbA1c by 0.7 to 1%. So sequential addition of oral agent is done depending on the glycemic control. So yes, if there is when you consider in patients, if there's a compelling need to minimize hypoglycemia, then so if a patient is an elderly patient, or if the patient has had a previous history of hypoglycemic attacks, then we have to see what the choice of second line drug is. What is the best second line drug that we can add to metformin that case. So the patient is already on metformin and lifestyle modifications, then you can consider an SGLT2 inhibitor or a DPP4 inhibitor or a thiazolidinedione or a GLP-1 receptor agonist. So these are the drugs that we generally say are best suited as second line drugs in this kind of patient. So then you have to if even with that, if it is not controlled, you can continue addition of either of these. And even with that, if the glycemic control is not achieved, then you can consider the addition of a newer generation of soluble insulin, which has a lower, not soluble insulin, newer generation of soluble insulin or a basal insulin with a lower risk of hypoglycemia. Yes, so this is the risk of hypoglycemia. So the risk of hypoglycemia in almost all the drugs is that, generally know that there's no real risk of hypoglycemia except with sulfonylurea and insulin. That we have to keep in mind. And other thing is, if there's a compelling need to promote weight loss or weight gain, we just, like we said before, diabetes management goes, the pharmacological treatment goes hand in hand with non-pharmacological treatment, that is lifestyle modifications. So we give the drugs to enhance the, and weight out of these lifestyle modifications, weight maintenance. The impact on weight has the weight management has a big impact on the glycemic control. So we have to see whether we need to promote weight loss or weight gain in these patients. And with that, we have to see what drug to really add. So in this case, of course, you can add SGL2 inhibitors or GLP-1 receptor agonists, both of which are weight neutral. And then you can continue, as a third line, you can add either of these again, or you can go to a carbos, which is given after meals. And if these are not tolerated or contraindicated, you can start a patient on a DPP-4 inhibitor. And if the HbA1c is above target again, you can try to cautiously add pioglitazone or insulin. Why? Because like you see here, metformin is weight neutral. The carbos has a weight neutral effect. DPP-4 inhibitors has a weight neutral effect. I'm sorry, earlier the SGL2 and GLP-1 receptor agonists have a weight loss effect. This is if you need to promote weight loss in a patient, right? So these SGL2 and GLP-1 receptor agonists, they have a weight loss effect. All others have a weight gaining effect. Then again, if the cost of drugs is a major issue, as is the case with a lot of patients that we, patients we come across in the clinics, then of course you can go for cheaper drugs like sulfonylureas or pioglitazone. And then if as a third line, again, we can go with those. And then if, of course, if the glycemic targets are not met with those, we cannot go for expensive of, say, this empagliflozin. In some clinics it's available, but in some it's not. If you are to buy it from outside, it's quite expensive for the patient. So in those cases, it's best to start with the basal insulin with the lower cost as the final agent that we consider. So likewise, I just wanted to demonstrate some of the things that you have to consider when adding a second line drug. This is an overview, in fact. So this is the general efficacy of the drugs that we use. So out of them, metformin has a high efficacy, and GIP and GLP-1 receptor agonist is combination drug. It has a very high efficacy, and GLP-1 receptor agonist also has a high to very high efficacy. And sulfonylureas, thiazolidinediones, those also have a high efficacy. And insulin also has a high to very high efficacy. And SGL2 inhibitors has a immediate to high efficacy. And the sitagliptin DPP-4 inhibitors have an intermediate efficacy. And so the effect on HbA1c is, so the most decrease, this is the reduction of HbA1c. So with metformin, you can see that it reduces it by 1. And in most, of course, you would see that the generally it generally the rates ranges near 1, but in sulfonylureas and insulin, in those two only you would see the most reduction in the HbA1c. Also in the meglinotides, you can see that there's a high reduction of the HbA1c. So this is basically an outline again. This I extracted from the 2022 local guidelines published by the College of Endocrinologists. So that's again what I said before, in fact. Yes, so the take-home messages from Dilini's presentation and mine are that, you should start screening at the age of 35 years. Screening for diabetes, and early detection of prediabetes and Managing will prevent progression to diabetes and its complications. And you have to encourage the patients for DSMES to achieve better compliance. And you have to consider initial combination therapy for those having HbA1c greater than 2% above the target. You have to take risk of hypoglycemia, cost comorbidities, and weight management into account when choosing a second-line agent. And consider addition of an SGLT2 inhibitor as a second-line drug for maximum therapeutic benefit for patients with atherosclerotic cardiovascular disease. And of course, you have to assess the CVD risk in all DM patients to consider statin therapy for primary prevention. And you have to start statin therapy in all patients above 40 years of age for primary prevention. So that's about it. These are references. Thank you.
Jayoda, thank you very much. It's really both of you all have done a real good job, and it's very informative and it's very the best according to the best scientific the evidences to the diabetes management. So you are in par with the international standards of diabetic management. So the update today you got it. So I am going to tell you for all juniors, right, that you all have joined with us recently. I'm going to tell you you have to be ready with to focus for the guideline management always, because then the patient safety can be ensured. So please be mindful to go and read about the guidelines about the common diseases, and as well as update your knowledge. And you have to be ready with doing such presentations that that these two people, the registrars, they have done a wonderful job, and they are the prepared these some the what those are called guidelines in the short that is we'll say some in a the algorithms, right, like that they have prepared that and put it to the training unit as well. So that's really the learning the process, that it will remain in your mind as well. So please take this home, take home message to be stick to the guideline management and to be ready with the conducting such presentations. Even though you are juniors, if you are ready, we can take it up to the weekly presentation in Thursdays, right? So thank you very much. And any the things you need to clarify, you can talk to your juniors, immediate seniors, or even to the being the college. I'm also there as the president, and our other senior consultant also there to help you all to clarify your matters since you all are new. So, and not only for the new people, but the whole other set of registrars, we are there to help you all. So thank you very much, and sorry that it was little bit late, but anyway, I hope that you have learned and extreme the gratefulness to Jayoda and Dilini. Thank you, dear. Thank you very much. Okay. Good night.
Thank you, madam.
Thank you, ma'am.
Okay.